everybody. So we have a very debatable topic. How good does quality initiatives impact the revenues of hospitals? So we have very eminent speakers, 4 of them. So I would like to call upon first Dr. Rohini Sridhar. She is the Senior Vice President, Medical Services, Hospitals Division at Apollo Hospitals Enterprises Limited. So thanks, ma'am, for joining today. And now I call upon another eminent speaker in the quality circles, Dr. Lallu Joseph. She is the Quality Manager of CMC Vellore and the Associate General Superintendent as well. She is also the General Secretary of Consortium of Accredited Healthcare Organizations. So thank you, thanks for joining today. Next I call upon Dr. A.K. Ravikumar, Chairman of the Nursing Home Board of India. Thank you, sir, for joining today. Lastly, I call upon Dr. M. Prabakar, the Managing Director of Kalyani Kidney Center, E-Road. He is basically a urologist and a transplant surgeon. I would like to ask Dr. Rohini. Ma'am, you've been working with Apollo Systems, Apollo Hospitals for more than 3 decades. And Apollo is known for consistent patient service. So my question would be, so what are the quality initiatives in the Apollo ecosystem that has helped it get this name?
Okay. So 40 years of hard work summarized in 2 minutes. I'll do my best. It's been a journey of evolution. I think sir will recognize from when we started off trying to put stuff into the NABH standards to where we are today, it changes. But even today, if you look at Apollo today, we have a spectrum of hospitals. We have a hospital in Karikudi. At the same time, we have a 800-bedded hospital in Delhi. So even today, after 40 years, we still see the same challenge. So if I think that I have solved a quality issue, maybe for the Delhi hospital, it is still a problem for my Karikudi hospital. And I think that's what quality is about. It's a continuous journey. And the initiatives and the processes that you bring on board have to be tailored to the situation and the needs of the individual hospital. So initially, of course, we started off with measuring the metrics that everybody measures. And then we realized that in measuring the metrics, somewhere you lose sight of what you're trying to do, which is basically improve processes and improve outcomes. So today, over the last 3 years, we have pivoted our quality systems to look at better outcomes for the patient. And in better outcomes for the patient, one thing which is very important is that we need to incorporate patient feedback. I would say some years ago we were not looking so closely at patient feedback as an important metric, but we now realize that it is. Even for your outcome, the patient feedback. And that's the reason that we are talking so much about patient-reported outcome measures. So we have pivoted towards outcome. The other thing that we are looking at very closely, and I think is something that all of you will resonate with because it's a challenge for every administrator, is appropriateness of care. Whatever policy or protocol you put in place, you want to make sure that for every patient who walks in your door, the right investigation was done at the right time and the right treatment was given at the right time. So we have focused a bit more now on trying to have these care protocols and pathways and audit them so that if a patient with chest pain, with a myocardial infarction walks into any one of the 74 hospitals, he will get the standard of care. So it is a challenge. I wouldn't say even after so many years of hard work we've solved it. We are looking at it differently. And even today we are still putting together several building blocks. Just one last point. I think many of our quality problems will be solved by tech. I was just discussing with Dr. Ravikumar, I think we should embrace tech. The more we embrace tech and the more we look at AI, it's not expensive really. It's for us to take the power and use it to make a difference. And it will make a difference where there are in smaller nursing homes, in more remote locations, the tech is likely to be your savior. So we have actually a very active a clinical AI program centered on multiple things, clinical as well as quality. And we hope that some of those initiatives will actually pay off really well. For example, we are trying to do both nursing and physician handovers using AI, generative AI. We are trying to look at discharge summaries through generative AI, because this is where most of the stresses and most of the mistakes happen. So we are trying to look at using some AI-based alerts in our medication management system. So some tech embrace also. And this is my brief summary.
Apollo has always been a pioneer in various initiatives, and tech with quality is a great combination, and we'll wait to see what difference it can make. So coming over to Dr. Lallu, you represent one of the oldest medical institution in the country, and CMC Vellore is known, it's a globally renowned institution. How do you see the journey of CMC Vellore, and what is your perspective of that journey, and what was your contribution in the journey as well? Can you just elaborate?
Thank you so much. Thanks for giving this wonderful opportunity, and congratulations to the organizers of AHPICON Madurai. It's indeed a pleasure to be here. Rather than saying CMC's journey, I would say CMC's journey into quality management and accreditation. So this started in the year 2007. It was not bed of roses. It was a very, very difficult journey, I must say. Considering that this is the 125th year for CMC Vellore, and the culture being engraved in the organization, it was very difficult to change the mindset. So in 2007, when we started with our journey, it was very evident that we had to do it, because single-bedded hospital grown to over 3,000 beds at that time, and today we have 4,500 beds. So Dr. Gyani was the person, I must say, to be appreciated for getting CMC involved. So he got many of us trained, and we decided to go in for NABH accreditation. This was in the year 2008. So in 2010-9, we started with our assessment process. We didn't have any procedure manuals, nothing in place, because everybody in CMC always said, we are the top in the country, why do we need protocols, why do we need SOPs, who are these people to come and assess us? So this team of assessors came in 2009, headed by Madam Gracie Mathai and 2 other clinicians. And it was like, I must say, a joke. What are they going to see? So this lady said, I have to go to the rooftop of the tallest building. And we took her to the Women and Children block that was just commissioned. And we reached the rooftop in 1.5 hours, because nobody knew how to reach the rooftop. It was designed by a gastroenterologist, so we were going from one intestine to the other, ended up in the stomach. End of the day, we didn't know where we were going. So when we reached the rooftop, it had construction debris, it had everything, alcohol bottles. Nobody had actually looked into it at all. And this lady said, let me climb onto the water tank. So no ladder, nothing. So somebody pulled out a ladder, we kept it there, and our Deputy Director Quality, an ophthalmologist, said, Madam, let's ask the others to climb. She said, no beta, I am going to climb up. So we were both standing like this so that the lady doesn't have a fall. So she climbed up and she said, can you get me a stick? And then our director said, let all of us run away, this lady is going to hit us now. So he said, Madam, the lid is very heavy. She said, no lid at all, beta. So the water tank that was supplying water to the Women and Children block, she pulled out a dead crow from the top of that water tank. And then it was like, CMC is a very closed organization. And everybody was like, oh, terrorists here trying to terrorize CMC. Let me tell you, that was the 2nd edition of NABH book. We had 256 NCs out of the 500 plus in the book. Everything was a non-compliance. But I think that was the best thing that happened. After that, in the next 1 year, everybody came together. And thereafter, there's no going back. It was, I would say, the involvement of the people has been wonderful. But the journey has not been straightforward. 15 years today, I can tell you that the culture is established in the organization. I just want to point out 3 things here. Number 1, the best thing that we did is to get the clinical teams involved. So every department, whether it's orthopedics, neurosurgery, neurology, we got one middle-level faculty as a department quality manager. So why didn't we go for the head of the department? Because they are resistant to change. So we thought at least let's get the middle-level faculty involved. So we formed a very robust quality council with about 180 plus department quality managers. They can only serve for a period of 3 years. All audits are done through them. Very difficult to get them involved, but today let me tell you, quality is in the boardroom. Starting from our director to all associate directors, deputy directors, the general superintendent, everybody has gone through our system as department quality managers. So now the culture has come in. They understand quality. They know the importance of quality. That's point number one. So it's all kind of, it's not overnight exercise. It's more to do with getting everybody involved and catch them young. And that goes on. The second important thing, what we feel is, being a teaching medical college, it's very important to catch them very, very young. So we started this initiative of clinical audits, making it mandatory for all our postgraduates and medical interns. So without our clearance, the medical intern doesn't get the clearance to move out of the hospital. So it's become a beautiful tool to get them involved from day one into some data analysis research. Can I have 1 minute, please? Sorry. So thereafter, now we are seeing that the postgraduates, the junior consultants, everybody gets involved in this exercise. So the beauty of this exercise, I feel, is that, you know, getting everybody involved, particularly the clinicians involved, and not expecting benefit overnight. Today I can tell you our documentation has improved, our statutory compliances. We didn't have fire license for most of our buildings. Today we have for all of them. And whether it is the consenting process, whether it is the disaster management preparedness, the educational level of the staff, the morale of the staff after this exercise has gone up, it's made a tremendous difference. And it's being acknowledged. And I feel it's a beautiful exercise that we went through, a very formal exercise, and it's really done wonders to our organization. And thanks to NABH and particularly Dr. Gyani for introducing us to this wonderful exercise.
That's great. Great to know the secrets of CMC, but I'm sure that Pro is not there anymore. Now we move on to Dr. Prabakar, who represents multi-specialty hospital, but a medium-sized, I won't say medium level, sorry, medium-sized multi-specialty hospital in a tier 3 town like E-Road. So Dr. Prabakar, I think, how long it's been since you got your NABH?
I got my first entry-level NABH. My hospital was the first in India in 2015 to get entry-level NABH, and 2017 I got my full NABH.
Okay, so what made you go for it? How crazy were you to go for NABH?
Basically, I never had any exposure of NABH till 14. My new hospital, once I was now having a 15-bed hospital, upgraded to 100-bed hospital. It's a multi-speciality with transplant and other things. And I was only consultant, so I was busy operating the whole day. But I was coming across a lot of problems in administration, which I was not able to handle. So I engaged association or the agency to run the hospital for administration side. So that is the time when the agency told me that you just get full NABH, you will run your hospital in autopilot mode. Then they worked for nearly about 1.5 years, but there was no improvement, anything. Then that is the time when entry-level NABH was introduced, and we were called by the Tamil Nadu government, whoever was doing CM Health Insurance Scheme, to the DMS office in Chennai, and we were told about these things, entry-level NABH. So then when I came back, and that is the day when I met Dr. Pichumani and Dr. Anuradha. They're from Chengalpattu, and they've got full NABH in 3rd edition. The major problem those days were 3rd edition was very strict on statutory requirements. My hospital was not as per the approved plan, so that was a major setback. But still they told you get the process and the SOPs and all the other processes ready so that your quality will change and it will become an autopilot mode. So just because I was having difficulty in running the hospital, I ventured into the NABH, and then once I knew that this is happening, I just applied because I just read that entry level thing and I didn't do any exercise. I just applied for it, and for my surprise, 2 months later, I got a letter saying that you have been awarded entry level NABH first in India, and I was called to New Delhi and I was awarded the certificate there. Then when I came back, I got a patient from Chennai. Erode to Chennai is nearly 400 kilometers. But I was not very happy about the work going on, quality and other things. I was in CMC Vellore for 2 years, so I know about the quality and other things. I was not very happy on that aspect. So that is the time when a patient came from Chennai for circumcision. I asked him, such a small procedure, why didn't you get it done in Chennai? Why you want to come all the way to Erode? Then he told me, sir, your hospital is the NABH. And that was only entry level. So that is the time which rang me a bell that the NABH has a value on that. And then I just changed the agency, and that is the time when Kaho was coming up, because those days we never knew anything about NABH, and not even a single objective element could be explained to us by anybody. So even though NABH was conducting a lot of programs, but that was just 1.5, 2 days program, and it will run off fast and we can't be very clear. So that is the time Kaho came out with one big initiative on training for NABH. So Lallu madam is a mentor for me. I have attended at least 25 to 30 classes of her, and I was the first student of her in certified person for quality implementation. That was entry level and full. Then I had the privilege to get my center recognized as Center for Quality Promotion to help other hospitals to get NABH. And still now, none of the hospitals in India, several hospitals have got the CQP recognition from Kaho. None of the hospital has broken my record of 35 hospitals which I have handled, and they have got NABH. So after that, I worked on it, and in 2017, I got my first full NABH. That was first in Erode, and then now that is the 4th edition. Now we have upgraded to 5th edition. So this is my journey, and now I could always say that it is in autopilot mode. And one more thing, as Madam told, getting NABH for a big hospital, for a multi-speciality hospital is very, very difficult. But for a single specialty hospital like mine, with few consultants, because the most resistant people to adapt this process and the SOPs are the doctors. So if you have more number of doctors, it will be very difficult for you to implement the processes. So that way, small hospitals and mid-segment hospitals, if the owner has the intent to learn it properly and understand the intent and implement it, then obviously any small hospital or any place they can get. So that lesson I learned from Dr. Anuradha and Dr. Pichimani. They had done 3rd edition in Chengalpattu. So that gave me a courage, and I started working on it, and I taught all my staffs, and now in my hospital there are 15 CPQH basic and advanced qualified staffs with me. My wife, my children, both of my son, everybody are qualified in the CPQH. So we have to first understand as a owner, only then in a small hospital setup. In a multi-speciality big hospitals, you have a lot of people, you have CEO, you have administrative officers, you have a lot of people to work on it. But for a small and mid-segment hospital in the periphery, you as a owner should learn it properly, and Kaho is doing a wonderful job. I should thank Dr. Gyani, Dr. Vijay Agarwal, who is not here, and Lallu madam to take an initiative to become almost an official training wing of NABH. So the amount of training they are giving is phenomenal, and I am lucky to be few of the classes also I have been a faculty with the help of madam. So this is the journey.
Yeah. Thank you, Doctor. So now over to Dr. Ravikumar. You have heard, sir, we have a representative from a corporate hospital. We have someone from a medical college, and another person from a single specialty from a tier 3 town, all propagating the message of and the importance of quality in their journey. As a representative of the larger group of nursing homes, what is the general opinion of doctors who own such nursing homes? Please, sir.
Thank you, Dr. Adel, for inviting me for this wonderful session. And I should thank AHPI, Dr. Gyani. So we have been traveling together for many years in this. And as you all know, India is a country where we have varied tiers of cities and varied levels of healthcare providers. these healthcare providers, if you take, just an example, I would say, during the COVID, you all will agree that all the Western countries who are supposed to have very good quality delivery and safety mechanisms, everything, they were well advanced than India. In spite of that, the outcome, if you compare, India has done better than all those Western countries. I hope all of you will agree with that. In that situation, really is quality healthcare the pace at which we go and the advances of the quality healthcare which we expect, has it done really a great change? It's only a thought process. Just that doesn't mean that we don't have to have quality healthcare. Actually, I would say that I have been practicing for nearly around 35 years, and the journey of the practice as a surgeon, I used to visit the remote places, the rural areas to do surgeries. The theatre will be only 10 by 10 with a doom light over there. A sister will be on the top, catching hold of the wrist and taking the pulse and BP. At that time, we didn't have even pulse oximeter. That was the days. And we did the surgery and we used to come off. And subsequently, as days went on, the development in technology came up and the need for the use of those gadgets came up. And we could see the sea of results changes. The pulse oximeter, the monitors, diathermy, all those things came in and which helped in giving the quality treatment. So that really has worked out in giving the quality health care. And accreditation process, definitely it has given a chance for the hospital to prepare towards the quality healthcare delivery. And this has changed the attitude and the look of the patient towards the healthcare, towards the healthcare facility. So that has definitely given a very big change. So the patients now, what they think is, what is their expectation is, they want quality health care at an affordable cost. That affordable cost, I will talk about this in the next question, which you are going to put in for that. So the patient's expectation is the quality health care at affordable cost. And we are marching towards that. And our quality implementation system, I think it has to cater for the remote rural hospital where they have to give the quality health care at the same time at the affordable cost. We have to design in such a way that the quality also improves. At the same time, the cost also has to be taken care of. So really, I am just putting forward the things of all the cadres of the healthcare system. So, at one end, the bigger hospitals with high quality, with high technology, that's good. At the same time, the smaller areas, there also we have to see that the quality is being delivered, but what type of quality? Should we follow the 5th edition strictly in the remote area? If you want to follow the 5th edition of NABH in the remote area, no hospitals can get the accreditation. And if that is going to become the statutory norm that you have to have this quality, unless you have this quality, you will be sued, then nobody can practice in the rural areas. I'll give a small example. One of my brother's daughter, they are in US. One Friday, she had preauricular sinus, got infected, severe pain. They sent a photograph to me. I saw that it was just bulging. She had severe pain. She went to the nearby hospital, and in the hospital they said that IND has to be done, but you have to get an ENT opinion, and ENT consultant only can do that. A Chinese doctor who was there, a junior doctor, he was about to say that to the senior, can I put an incision by giving a local? No, you should not do that. Only an ENT surgeon should come and do that. Then she got 3 days. Later only she got the appointment. She had to suffer the pain. Whereas in our country, in my hospital, if she had come here, just at the bedside, give a local, just open it, the pain would have gone. Then you get the ENT opinion, go for the definitive procedure. So all these things we have to think and then implement. Thank you.
Thank you, Doctor. So your inputs have given me two different ideas. So, but let me first start with, I'll come back to Dr. Lallu again. You've been the General Secretary for CAVA for 2 consecutive terms, and now we are talking about quality, we are talking about accreditation. I would like to ask a simple question. Is quality and accreditation the same or not?
It's certainly not the same. Accreditation is just the beginning, I must say. Or rather, quality management is it's a very large basket, and accreditation is one of the best possible tools that you could use to reach where you want to go. And it's a process, it's a continuous improvement process. So I would certainly not endorse that quality is accreditation and accreditation is quality. They are totally different, but accreditation is something that will take you there. And it's just a beginning of your quality journey. That's my answer to your question, if that answers.
Yeah. And to Dr. Rohini, I would like to understand, Dr. Ravikumar was talking about affordability.
Okay, before I go there, Adel, if you'll permit me, I just wanted to add something to what Lallu said. It's true that accreditation is not quality, they're definitely not synonymous. But what we have seen quite often is once you get accreditation, it gives you a sense of complacency. That yes, we are now done, whether it's JCI, NABH, NABL, whatever it may be, so now we are the best. I think that continuous journey, that accreditation is an entry point. It's just like you cross the gate onto the other side, and that is where your quality improvement will begin. So we should look at it like that. It's a constant journey, but very often we see even within our own organization that once you have ticked the box, oh, we completed NABH with 3 NCs, is a cause for celebration. I'm sure it is. I won't take away the credit, but I think quality goes much beyond that, and I think we need to emphasize that, which is why I just wanted to add to what she said. Yeah,
I agree. So I was just asking, like Dr. Ravikumar was talking about affordability, and I know the kind of initiatives Apollo has, your Apollo Clinical Excellence, parameters, and multiple initiatives. After implementing many such initiatives in the quality domain, are you able to keep your cost low, or has it increased your cost of service?
It's a little difficult question to answer. See, if you look at it from one perspective, and I just want to give you a comparison that we did. If you look at a quality outcome for a procedure, and we did this with CABG, right? So you take the CABG outcomes of the top 10 hospitals in Apollo, and we compared it with published American literature. So for the same outcome, if you take CABG mortality as an outcome, they had reported a CABG mortality rate of about 1.5 odd, and we were at about 1.4, comparable. Their cost was almost 5 times as much. So definitely if you look just from that prism, and I'm not saying it just because it's Apollo, I'm sure if you ask Dr. Satish with knees, he would find it very clearly that our outcomes are comparable to the best. We can say this with complete confidence on every metric that you choose to measure, and we are doing it at that 1/5, 1/4, 1/10 the cost. So I think one of the things that we now realize is that these protocols and processes that we have developed are helping us to achieve that kind of quality at a much lower cost. But if you are asking what has happened to the cost of the procedure over years, yes, it has gone up, but the reasons are distinct and different. It may be related to input costs. I think now the biggest challenge for us is manpower. Manpower costs are going up as perhaps they should, and that's a challenge for us. But I think definitely quality, I mean these accreditation processes and protocols that you have done enables you to give error-free standardized care. And in that sense, you are able to achieve it at a much lower cost. This is our experience.
Coming back to Dr. Prabakar, as a hospital promoter, and you're running a hospital in a Tier 3 town, I keep repeating that for a purpose. So just wanted to understand, as the theme of the conference is about sustainability, how did these quality initiatives help you in the sense of business? Has it helped you sustain your hospital business revenues? Can you just elaborate on that, please?
Yeah, I can answer this question in two different headings. One would be implementation, the cost of implementation of these process and other things. Definitely initially it is high. For a small hospital and a single bed hospital, single owned hospital. We had a lot of challenges. That was a big thing because, when we wanted to implement the hand hygiene technique, our WHO hand hygiene complaints rate was only 50%. So then we had to come out with some new ideas. If a quality person or the infection control nurse goes to a department and if she finds out that the hand hygiene techniques are not properly followed, the in charge will get 2 days off cut, and the person who has not complained will get 1 day off cut. That's because that improved the in charges catching these people better way. So that is how we could reach a complaints rate of 98%. So that was the initial challenge. So now it has become slowly, culturally they have gone into this, and it has become a subconscious way of handling it. So that is one thing. The second thing is the simple tools. See, like corporates like Apollo Hospital and other big hospitals, there are people to counsel, there are people to do everything. But for mid-segment hospital in a small town like ours, we need to do everything. So these tools, give us a very big advantage. For example, early warning score. You can catch a patient 6 hours before he goes critical. It really matters for us because in big hospitals you have very good qualified staff nurse because they want some experience with their background in that name. But for us, we don't get that good staff nurse and they keep changing. So what happens when the patient post-op has a fever? The patient, you have a good dual doctor around the clock in a big hospital. But here, only doctor we are available is me, and they call me in theatre and they ask the patient has fever. That's all. That much only they can pick up, the staff nurse. But then I'll say, okay, give a paracetamol and leave it. But this early warning score, a simple tool, can empower a staff nurse to shift the patient if it goes more than 3 to the ICU before the complication is clinically established. So which in the other sense helps us from litigations and hospital attacks. Because in a small hospital, the major problem where hospital attack appears is the patient goes and worsens, the attenders come and keep on repeatedly coming and complaining that the patient is not well, we don't take care. After that, we shift the patient to ICU, and if the mortality is there, they don't accept it. But with this simple tool, we shift the patient before the clinical presentation comes on this acute things, and even the patient attenders are surprised. He looks okay. Why should you want to shift? But then, once you shift, they are very happy, and that part of thing is taken care of. Similarly, surgical site marking. We do a checklist inside the theatre which doesn't know by the patients or attenders. But when we do it in the ward, previous day, surgical safety checklist, site marking, they ask why you do it. So then we say like, see, sometimes, they all read the paper and instead of right kidney, left kidney is operated. So to avoid this, we are doing this. So these things, improve our the morale of the treatment and the involvement and the adverse reactions and double checking. These are all very, very important things which is already practiced in big hospitals. But once you practice, again coming to the cost, when Ravikumar sir told, we in periphery, we are catering 80 to 90% of the patients under CM Health Insurance Scheme. It's a package which has not changed for last 12 years. So what will happen if the patient has post-op infection? We will have to pay from our pocket because it's a package, includes all medications. The insurance company will not pay extra. So if your infection rate has come down, you're at gain. So that way a small and periphery hospital will gain more in the long run if you have a proper quality setup rather than you're not implementing quality. That will take a toll on your 10 cases you learn, in one case it will go off. So that is a major challenge in a periphery and a small hospital. So that way I think it has given a very big thing for me.
Coming back to Dr. Ravikumar, sir, we are talking about cost share and sustainability. So, and Dr. Prabakar was talking about cost of implementation. Yeah, quality does come with a cost. But for a hospital promoter in a tier 2, tier 3 town who's just running a 50-bed nursing home, so how can he or she manage that cost at the same time be affordable to the patient as well?
Yes, sir. To open this, I'll just give a basic cost. So which the Indian Medical Association, see why we went in for costing study basically is, as Prabakar was telling, the packages which the insurance companies, whether it is the government side schemes or the private, the packages are very, very less, which cannot sustain. It's very low. So whenever we go for dialogue with the insurance people, they say that when so much of hospitals can do for such a low cost, why you are asking for a higher cost? And do you have any data? So we had a thought that we should do costing. Because major hospitals, it is a business model and they will definitely, before starting a hospital, they will work on return on investment. But 80% of the small, medium hospitals, they don't do that at all. They just plow the money, they collect the money in the evening, next day they plow back into that without knowing where it is going, how it is going, whether they are making profit or not. And 1 week they will go on outing or somewhere else, and after 1 week they come back to the hospital and they will suffer to pay the salary of the patients. That is the thing. So what IMA we did is, we will just do costing. And we did the costing as per the government standards. The government had given the CEA 2010, it has given the standards for the basic hospital. A hospital means that must be this. These are the quality things which you have to maintain in the hospital. So based on that, we did the costing. And we were shocked to see that unless, yes, 50-bedded hospital, with those quality standards, if you want to run, per day room charges must be 5,000 plus. 5,000 plus. Whereas, when you ask any of the medium, small hospitals, their room total charges will come around 2,000, 2,500 rupees. Then the costing accountant asked, how come doctor, I can't take anything out of this, from this. So how is that you people are able to manage? Then the thought process came in and we just saw, in this crowd I'll just ask you, how many of you are doing 8 hours and 200 days and year work? Doctors. only 8 hours per day and 200 days in a year. Can any of you put up your hand? See, according to the quality standards, a doctor professional should work only for 8 hours a day and he should work only for 200 days a year. As doctors, we work for more than 12 to 14 hours a day and 365 days. If year contains 400 days, then also we will be working. So we are able to manage because of overwork, one. Second thing is, the staffs who are working. Wonderful talk today, morning I heard from the nursing team. Our staff in the medium and small hospitals, they work 12 hours, 2 duties, 12 hours. And they multitask. Our nursing, I think madam, she was telling that you specify the work and give the work which she is interested. But in the small, medium hospitals, you cannot have like that. You cannot have an ICU nurse, you cannot have a theatre nurse exclusively doing the theatre work and the nurse for ward work. So we want that nurse to multitask. Only by such multitasking we could meet the ends. We are able to meet the ends. That's how the costing has opened the eyes. So if you want to give that quality, safety, everything to our staff and also the quality care, then we have to increase our charges. No other go. We have to fight with the insurance companies now that the universal health care is going to come in. Every citizen is going to come with a card to your hospital and he will pay only cashless and the insurance companies will squeeze. So that is the status. But this quality health care definitely is a boom, I would say. For example, in my hospital, one day I was having the cylinders only, earlier. It's almost 26 years since I started my hospital and we were having only cylinders earlier. One fine day what happened is, cylinder was full, everything, the mask, everything was in the cylinder, but key was not there. Patient is having breathlessness, we have to give oxygen, but people were running around to get the key to open the cylinder. Then I thought we should have a central, central system. And central system, each and every room I have a suction and oxygen unit implemented there. And we have a checklist in each and every room. So the checklist contains each and every point, about 20 points are there inside in this checklist. Daily morning, a person has to go see that including the kidney tray, everything they will see, they will tick it and sign it. Once that is done, absolutely free. So this process of quality implementation is definitely helpful and that doesn't involve much cost. And regarding the cost, I think the next question I will answer because already she has buzzed it out.
So actually we're very short of time, but Dr. Ravikumar, as you said, like it doesn't matter who does the job, it is important that the process is followed. And you can either do it with a dedicated staff or do it with a multi-skilled staff. Okay, lastly I will come back to Dr. Lallu to understand. You have been involved in a lot of national forums and through CAHO also been doing a lot of quality revolution, leading the quality revolution in the country. Can you just elaborate on what is the future of accreditation and what are the national quality initiatives that are happening in the country now?
Thank you for that question, Adel. And I think the most important thing is to get most hospitals in the country accredited. Despite 15 years of accreditation journey, we still have just about 10% of the hospitals accredited or certified. So as Madam rightly said, it is the basic minimum standards that we are talking about, and it's very important that every hospital goes through this. Whether in the form of a CEA checklist or NQA standards, it's not something that every hospital has to go through NABH, but at least some basic minimum standards with regards to if it's a labor room, the Lakshya or Manyata, some basic minimum standards so that we ascertain the right quality of care is delivered to our patients and the quality care is ascertained, the patient safety is ascertained. That's very important. So that's the first thing I think that we have to lead by example, getting all our hospitals certified or accredited. Without that, there is no guarantee that we have got systems and processes in place. And whatever we say, the cost of poor quality is going to be extremely bad for the organization. You may be doing 100 cases with excellent outcomes, and you have one case like the mother of Sridevi who went through the wrong side, operated, you're gone. That happened in Sloan Kettering in one of the leading centers in the US. So it could happen anywhere. So the cost of poor quality is something that we cannot afford today. So that's very, very crucial. So basic minimum standards and accreditation journey for all hospitals is one. Second thing is the hospitals that are accredited over a period of time. Let's say Apollo, 15 years of accreditation, or CMC, 10 years of accreditation. There are many hospitals that have gone through 3 or 4 cycles of accreditation. Now every time we are going through the same process. You know, NC is coming in, you now know how to break the code also. How to close the NC. We have got standard documents available as to how to close the NC. It's almost become like a tick list today. So what is it in for hospitals that have reached that level of excellence and want to go beyond accreditation? That is where I think there is a wonderful project that is now coming in. It's trialed out, the grading of hospitals by the Quality Council of India. It's already trialed and tested in 8 centers in the country, the leading centers. It's going to be a path-breaking exercise, I'm sure, because this is going to lead you with process-related, outcome-related indicators, sustainability coming into the picture, patient experience, service provider experience, technology in a big way as to how your hospitals have adopted to technology. So that's the next step which I'm sure the country is looking out for. So I think there are several challenging opportunities also. I mean, lot of international players also coming into the market. Now what to choose from, whether you want to really go in with your Indian standards or you want to go to the next level with JCI, ACHSI, lot more. Now the new player in the ground is AACI, and then you have too many players. The ISO global standards have come in. But whatever it is, I think the intent is the same for everybody. It is all to do with excellence. And another important exercise which I feel is sharing best practices. We have many conferences happening where today hospitals are coming out with good best practices, and what we are now lacking is actually putting them in documentation, which is a compendium of best practices to learn from hospitals, other hospitals. You don't have to repeat the same mistake what others have done. So in order to do that, it's important that all of us come together as a consortium, put the best practices, share best practices, and take all our hospitals together towards that level of excellence. It's now a huge divide. You have hospitals that have not gone into any accreditation or certification. You've got world-class hospitals, but how do you bridge this gap? So unless we do that, it's going to be a challenge. And I feel the next probably few years, we have excellent opportunities opened in front of us, and it's for us to imbibe. If we don't accept change, I think we'll become redundant.
Thank you very much. And I have to apologize to my panelists as we're short of time and I have to sacrifice some of one round of questions with all of you. But yeah, I would take pride in agreeing with my fellow panelists in the fact that, as Dr. Lallu was saying, cost of poor quality affects you more than cost of implementing quality. And there is no other way around it. And that is the only way for survival. Leave alone sustainability, that's the only way for survival, and that will only lead to a sustainable business, hospital business or growth. So I thank the panelists. Apologies from my side again. We will close the session for now. Thank you.
Thank you so very much. Gently requesting the panelists to please stay back for the felicitation. Requesting Dr. Satish to please felicitate Dr. Rohini Sridhar Thank you, ma'am, for presiding over this session. It was great. Thank you. A round of applause for all of us, please. Felicitation over to Dr. Lallu Joseph. Memento over to Dr. A.K. Ravikumar. Memento over to our speaker, Dr. M. Prabakar. Thank you, Mr. Adel, our organizing secretary of AHPICON.